Hello, everyone. Thanks for taking the time to listen to this. My name is Dallas, and I'm a master's student at the University of South Alabama in the School of Computing. Um, I'd like to take a little bit here to talk to everyone about the benefits of and motivation, impetus for implementing an EHR system. And ultimately, the goal is to be in a state of HIE or health information exchange. Uh, so let's just dive on in. Now, first, let's just establish what an EHR system is. It's an electronic health record system. It's a way to digitally store, manage, and use, access, etc., make reports from. Digital systems or repositories, databases with patient health records. Um, Normally, these are going to be database driven. Um, Ideally, the database will be normalized, meaning that the relationships between the entities are primarily made in a way that queries can be robust and also reliable. Um, and the EHR system is also going to be a brand new way for everyone to interface with the health records. Instead of having a filing system or a filing cabinet, there'll be a graphical user interface on a tablet or a computer or laptop or terminal of some sort. Um, and these interfaces are going to have been built by software developers in tandem with people in the industry in order to optimize the workflow. The EHR we'd be getting would need to be government certified anyways. So these systems have been developed and worked at by people who really know the workflow that we have in the health industry. And another good thing about it is the simultaneous access by several individuals, and of course, got the data persistence and the reusability that comes with having digital records as opposed to paper. So why do we need an EHR system? Well, first and foremost, and maybe most importantly, is that it's required by the government if we don't want to start having our Medicare and Medicaid reimbursements reduced. They would be reduced by a flat percentage that would increase each year that we are not in compliance. Um, as if that weren't a big enough reason, if we're compliant, there are financial incentives of equally significant amount. In fact, it's something like 44,000 for Medicare and 64,000 for Medicaid per provider at a practice. So if you've got several providers, that can really add up. Another big reason is the collaboration it would enable, not only between us at the practice, but it would also allow the patient to be more involved with asking questions, to be more involved with doing research themselves through resources that we make available, um, to be more involved with their own healthcare through being able to access their own health records or submit their own health forms or their own insurance forms online to our system to save us work in the office, to save us administrative overhead. Additionally, to sort of spread out all of the data entry into all of the different roles in the practice, not just the, kind of at the take in, the clerical staff sort of just doing it. It's everyone from the doctor or the nurse practitioner or whoever to the front staff to the customer, or I'm sorry, to the patient. Um, Everyone can sort of have access to the same source system and be able to contribute to putting in all this information that normally we have to fill out multiple times and is then hard to find. It would eliminate a lot of rework, like I was just saying, with being able to not have to fill out the exact same basic information about a patient into multiple forms, for the patient to not have to fill out the same basic information multiple times. And then finally, the data metrics that we could be making use of, that we could be learning from, that we could be doing a lot more with, sort of seeing where we're dropping the ball or on use, and then to also kind of see, what things the patients avoid. Now, what are our options if we're complying with these regulations? Well, there's MIPS, which is the merit-based incentive payment system. That's kind of the default option. That's the one you kind of have to comply with unless you choose to do your own advanced APM, which is kind of an advanced alternative payment model where you can customize from a more extensive list of metrics that need to be hit, that may be more suited for certain specialized doctors, or just for a practice that's very focused on achieving all of these things, because normally the advanced APM is going to be more compliance, more electronic health record use and proliferation and system, normally an advanced APM compliance model is going to be above and beyond the MIPS. The main thing with both of these ways of complying with the regulations, there are these 4 buckets of meaningful use, in which there are different metrics that can be reached within each of these, and a certain number of metrics within each category need to be reached for different tiers of meaningful use, each tier qualifying a physician or what have you as being in compliance with that tier of meaningful use, making them eligible for that tier of reimbursement, incentive, or what have you. With quality, some of you may have known that as PQRS. It covers the quality. I mean, that's obvious. It's just going to be a lot of different things assessing, how good the care is. The improvement activities is one that just sort of shows how you've improved things as you've gone on in time, how you've increased access or how you've enhanced patient engagement, that kind of thing. The promoting interoperability is kind of that has to do more with the health information exchange aspect. That's kind of like being compliant in that you make your patients' records digitally available in a common format or in a common way that's accessible to the patient, accessible to other practices, to other providers, to insurance companies, to regulatory bodies, that kind of thing. I mean, that's going to help everyone with coordinating care, with sharing test results. That's just going to improve the care for our patients a lot, and it's going to improve everyone's lives in the industry. And then finally, there's cost. And there's not much to say about that. That's kind of a recent addition. It's kind of your cost to your total care in the year. And I guess it's just weighted against other entities of similar size and scope. Now, what challenges do we have to expect? Of course, there are going to be challenges. There's always challenges, and there will be some pretty substantial challenges with implementing a system, an electronic health record system like we would need to do. One of the biggest ones is it's a new tool, it's a new system, it's a new workflow. It's a lot to learn for people, and it's stuff that they'd have to learn on the job while simultaneously still doing their normal job, possibly without the normal workflow and tools, paper tools that they're used to having. And so it's a lot to ask of everyone from the top to the bottom, and it may require additional training, perhaps classes, um, or if they have videos from the whatever developer we go with for their software suite, things like that, documentation. We may need to commit time and resources to that prior to rolling out the system so that everyone isn't totally overwhelmed with the transition. Another issue we could run into is kind of like, whose idea is this? You know, why are we doing this? Why is this happening? Who's responsible for fixing things? That kind of thing. And that kind of just, that just kind of takes everyone being committed to using the system and to taking ownership themselves and to being involved and, being committed to being involved from the beginning to the end. With testing the system, giving feedback to the developers for any customizations we need. Everyone needs to be involved and committed from the beginning of the process, not just thrown in at the end once the system is ready to be deployed. That's one good way we can really avoid a lot of trouble. If we just let everyone know about it, let people be involved, let people voice their concerns and their hopes for the system. One of the biggest things is the cost. The software costs are going to be substantial. There may be licensing fees, there may be yearly subscription fees just for the software, and then for development or support hours from the vendor, it's going to cost a lot of money. There may even be additional customization that we need done that may cost a significant amount of billable hours, but all of these things really, while substantial, are needed for us to be compliant and to really provide the level of service that patients are expecting today and that everyone else is beginning to provide. And not only that, but will benefit internally from the workflow improvements, from the administrative overhead cost reductions, from all the forms and paperwork that we don't have to deal with tangibly. Finally, I just want to touch on the concept of HIE, or an electronic health information exchange. We'd ultimately like to have our record system be able to either export records, patient health records, in a universal format that the patient could then use or have for themselves, or to be able to export it to another health system or an insurance provider's system of some sort, or even a health repository database of some sort, for a registry of some sort, or to have a published API to our system to where other entities could using the API with appropriate authorization, pull patient health records or other records from our system in a format that they could then just use directly. Obviously, this helps the patients. It helps avoid remissions, helps avoid medical errors. It helps us to improve diagnoses and to decrease duplicate testing. I mean, it would really help to decrease duplicate testing, because sharing test results, sharing X-rays, how many times are X-rays taken because X-rays at another provider are not available or not readily, quickly, able to be retrieved. And I just want to thank everyone for listening and for taking the time to learn more about why we need electronic health record system here. Thank you.